Next speaker is Princess, I always have to read the name, Imoudkhuede,
Yeah, Imoudkhuede.
from the Department of Bioengineering, where she's an assistant professor. And you joined just this fall, correct?
Actually, this January.
Just January. Okay, go ahead.
First, I'd like to thank the organizers for giving me the opportunity to speak. My research that I'm going to present will discuss how systems biology can inform on the process of angiogenesis, and more specifically, how we can use these type of nanomolecular tools to study the vascular microenvironment. So the concepts I'd like to leave you with will be the use of nanotechnology, using that to inform on vasculature, as well as combining that with computational modeling to predict the state of the vasculature and to predict novel therapeutics. And this type of iterative approach, going between experimental methods in nanotechnology as well as computational modeling, I think is really where we can, that interface is where we can advance therapeutic development. So just so we're on the same page, I wanted to give you a little bit of background on the process of angiogenesis. This, of course, is the growth of new blood vessels from pre-existing microvasculature. And it's important in development, exercise, wound healing, as well as in the female reproductive organs. And this schematic actually shows roughly how this process occurs. A cell that's hypoxic, which is under low oxygen levels, will upregulate HIF-1 alpha, which will lead to the expression of VEGF, secretion of VEGF, and binding, once it's secreted, to VEGF receptors on the surface of endothelial cells. This triggers the proliferation as well as migration of these endothelial cells towards that low oxygen gradient. And that's really how these tubules and then these vessels are formed. There are a lot of other processes involved, the work of matrix metalloproteinases to digest the extracellular matrix components, but roughly what you should take from this is that VEGF is a key signaling molecule in this process. And of course, angiogenesis is important for actually over 70 diseases, including breast cancer as well as cardiovascular disease. And these panels on the bottom show examples of this, where in peripheral artery disease, blockage of artery leads to ischemia, and actually these images show a critical limb ischemia, and how that would progress towards gangrene, ulcers, and at the stage of critical limb ischemia, about 20% of the patients will die within 6 months, even with limb amputation. And there are actually no current medical therapies available that correct for this impairment in blood flow. Actually, exercise is the most effective approach, and that's due to the fact that VEGF and VEGF receptor 2 are significantly upregulated in the process of exercise. And then the schematic here shows that tumors actually unable to grow larger than a few millimeters in diameter without recruiting its own vasculature. And again, that occurs through the secretion of VEGF, and over time, tumor is able to recruit its own vascular supply and grow much larger. So, of course, targeting this process would be very important in the treatment of different cancers. And there's been a meta-analysis that's been done to show that VEGF can actually serve as a biomarker for tumor state. So here you can see that in various forms of cancer, healthy patients versus those who have cancer, they have very different levels of VEGF in serum, plasma, and in some studies, whole blood has been assayed. So VEGF is, of course, not just a critical molecule for this process, but can also identify that we're dealing with a cancerous state. Now, when I speak of VEGF, it's a very complex set of signaling interactions. There's VEGF A, B, C, D, as well as PLGF, which binds to VEGF receptor 1. There are 3 main receptors: receptor 1, receptor 2, receptor 3. They form homodimers upon binding of VEGF. And they can also heterodimerize, so receptor 1 can form heterodimers with receptor 2, receptor 2 can form heterodimers with receptor 3, and then each of these have soluble receptors. Now, that picture is a little bit more complex when we consider all the splice isoforms, as well as the binding of VEGF to GAG chains and other extracellular matrix components, as well as considering the co-receptors, neuropilin-1 and neuropilin-2, which form complexes with these VEGF receptors, enhancing the binding of VEGF to its receptors. And this complex set of interactions can be better understood through systems biology methods. So here I show that basically those binding interactions, we model these with a series of ordinary differential equations. So the secretion of VEGF, the binding to each of these different receptors, all the possibilities, as well as identifying how an anti-VEGF agent, so something like Avastin, might affect the levels of VEGF systemically. So we do this on the endothelial cells, and we create a whole body model of this process. So looking at tissue, looking at blood, and looking at tumor. And we have skeletal muscle within the tumor compartment, as well as tumor cells within that tumor compartment. So this type of modeling allows us to then identify how the introduction of this type of anti-VEGF agent can change tumor levels of VEGF. And the model that was published by Marianne Stefanini and others has shown that, at least in the tumor compartment, injection of an anti-VEGF agent or bevacizumab initially decreases VEGF levels, and then it will return to baseline over time. And this model actually showed that there was no change in normal tissue levels. This is the blood levels. No change in the normal tissue levels and no change in the tumor levels, which altogether this didn't mirror what was seen clinically. But another advantage of this type of model is the fact that you can do different type of dosing and see what effect that would have on VEGF levels in the blood. And again, I'm saying that this didn't mirror what we see clinically, because clinically, actually, the anti-VEGF agent increases VEGF levels. So this led to the question of what's happening, what's wrong with these models that we're not actually capturing what's happening within the body. And we looked at how VEGF receptor levels, so VEGF receptor 1, receptor 2, as well as neuropilin levels, how that affects VEGF levels. And this type of sensitivity analysis allows us to see that understanding the levels of receptors on the cell surface is critical to advancing these types of computational models. So my work has been to sensitively measure these levels of VEGF receptors on the endothelial cell surface. And those models that were previously developed really looked at some of these clonal as well as overexpression systems as a model for those receptor levels. You can see that those systems actually had very broad ranges of receptors per cell. So again, being able to accurately and sensitively measure these levels will allow us to advance these computational models. And the approach that I've used is really where we start to look at nanotechnology as well as sensitive biophysical tools. And this is a quantitative fluorescence approach where I take beads with no number of phycoerythrin molecules, create a calibration curve based on that, label our cells with antibody conjugated to that same fluorophore molecule, phycoerythrin, and then use flow cytometry to measure fluorescence. And then from there, we can identify the number of receptors per cell. And there are a number of optimization steps that are involved with making sure that this is done in an accurate measurement, manner. One of which is testing the specificity. Here you see that I used porcine aortic endothelial cells that express human VEGF receptor 2 and receptor 2 as well as neuropilin. You can see that these antibodies are highly specific. I've also looked at these antibodies and their ability to to be able to measure monomers as opposed to dimers, and doing these FRET studies, again, with flow cytometry, I show that the fact that we see FRET shows that these antibodies can and do recognize monomers. I've also examined the conditions in which we label and assure that we're under saturating conditions. And cell dissociation is also very critical to examine. Here you can see that neuropilin levels are significantly affected by the use of trypsin in lifting HUVEC cells, so the in vitro culture. So for in vitro culture, we actually only use a chelating solution so as to preserve our receptor levels. And when I did this in vitro just as a proof of principle, I show that receptor 1 in vitro in HUVECs, that's in a macrovascular endothelial cell, human dermal microvascular endothelial cells, as well as a microvascular lymphatic endothelial cell. The receptor 1 is just about 2,000 per endothelial cell, receptor 2 is anywhere between 4,500 to almost 8,000 per endothelial cell. And neuropilin-1, which again is that co-receptor that I mentioned, is anywhere between 70,000 in the HUVEX and the MEX to 35,000 in the LEX, so an order of magnitude higher than the VEGF receptors. So as I mentioned, the rationale behind doing this type of quantification is to advance these models. So to do that, we wanted to do this in the in vivo, or I would say ex vivo condition. So here I actually tested a number of cell dissociation enzymes. So when we're identifying our endothelial cells, we have to dissect, dissociate, digest with these enzymes in order to get a single cell suspension. And here I did this in HUVEX to show that neuropilin is actually very sensitive to these types of enzymes. So for the in vivo or ex vivo analysis, we don't include neuropilin. And the next step would be to isolate these endothelial cells from that skeletal muscle dissociated tissue, and there I'd use a magnetic bead separation method, and then, of course, doing the calibration and labeling. But ex vivo, there's an additional step. So in isolating these endothelial cells, this antibody that we use, CD31, also recognizes monocytes and macrophages. So I use a CD34 marker as well, conjugated to FITC, as a secondary selection method. So when I do the quantification in vivo or ex vivo, we actually use both PE as well as FITC, but only quantify using the PE. So when I do this in skeletal muscle of mice, normal mice, non-tumors, we see about just under 3,000 VEGF receptor 1 on the cell surface, and receptor 2 is about 1,600. In the tumor, so tumor endothelial cells, we see about 7,500, almost 8,000 receptor 1 on the cell surface, so highly upregulated in the tumor endothelium. And the tumor cells have much lower levels, so about 1,500 of these. And VEGF receptor 2 in the tumor endothelial cells, it's about 1,600 and about 1,000 in the tumor cells. So when we plug these back into our computational models, as I was mentioning, again, this anti-VEGF agent, when it's injected in the previous model, actually showed no net increase in the free VEGF levels. But in our revised models with these new data, we actually show that the tumor, so let's look at the red panel. So the blood levels of VEGF actually do increase, which is what is seen clinically. So these models with the accurate levels of the receptors are now actually modeling what we see in patients. So this modeling is now showing us, allowing us to track how VEGF levels also change in normal tissue, which, so in a person who has breast cancer, how their normal tissue levels of VEGF are correlated, and as well as in the tumor environment, which these are data that are unknown, but are important in better understanding this environment. And these models also allow us to look at how the anti-VEGF agent, how that complex is distributed over time, as well as the complex of a complex anti-VEGF plus VEGF agent. We can see those dynamics as well. So I think that in addition to being able to understand what's happening with this type of an agent, being able to predict how novel therapeutics can be developed is really the power of these computational models. So one of the things that we've looked at, a couple of the things we've looked at are how microvascular permeability changes, so maybe targeting microvascular permeability between normal and blood, normal tissue and blood, as well as tumor and blood, changing the microvascular permeability, how that would affect free VEGF levels. And if you look at these two panels here, actually by decreasing microvascular permeability in the blood as well as in the tumor, you would actually see significant decreases in VEGF levels. And if you were to change microvascular permeability between the tumor and the blood, that's where you would start to see, if you increase microvascular permeability there, that's where you would see more effective treatment of this anti-VEGF agent. that's really, so combining this type of permeability analysis, I think, would allow for novel therapeutics to be developed, and this is where we're looking at now and collaborating with researchers who create some of these nanoparticles. So if we can create a targeted particle that can increase microvascular permeability in the tumor while decreasing microvascular permeability in the normal tissue, I think that's really where we can see improved therapeutic treatment of Avastin or bevacizumab, or drugs similar to that. And here we see that clearance rates, actually, that's not going to be as an effective, increasing clearance wouldn't be as effective as you might think, because what's limiting is actually the binding of the anti-VEGF agent to VEGF. And of course, if you decrease or basically allow for greater binding of VEGF to the antibody, you would see a significant decrease in systemic, so normal blood as well as tumor levels of VEGF. So now that I've shown you how this combination of this nanotechnology quantitative tool with computational models can inform on the vascular microenvironment and inform on therapeutic development, I thought I'd also show you how this type of quantitative nanosensor can also can provide insight into different questions in vascular biology. So first I wanted to show you how you can look at anti-angiogenic drug effects. So here we looked at pennistatin, which was previously shown to be an anti-tumor agent targeting beta-1 and beta-3 integrins. And it's also shown to have anti-migratory as well as anti-proliferative effects on HUVEC cells. So I tested these in HUVEC cells and actually show significant downregulation of neuropilin-1, which again is a pro-angiogenic co-receptor, and an upregulation of VEGF receptor 1 as well as thrombospondin receptor, which are both anti-angiogenic. So this type of quantitative approach can be used to screen drugs for their effect on other angiogenic receptors. This type of quantitative approach can also be used to identify skeletal muscle characteristics. So in the quantification of the skeletal muscle, I actually looked at two different muscle types: gastrocnemius, which is a mixed muscle tissue; tibialis anterior, which is more purely glycolytic. And I show that these actually have differential levels of these VEGF receptors. I've also looked at strain differences as a proxy for differences in human population, and actually show that BALB/C, which is a less angiogenic protected mouse strain, has consistently, you can't see it in this ensemble average data, but we do also look at cell-by-cell data, and that's where we really see the differences. But there's significant differences between BALB/C and C57 mice, significantly higher levels of receptor 1 in both of those tissues. So this type of quantitative approach can uncover some of the characteristics within endothelial cells and skeletal muscle. This approach can also be used to monitor changes in ischemia. So I mentioned peripheral artery disease as a disease that can be treated using a therapeutic angiogenesis approach, and a mouse hind limb ischemia model where you ligate the femoral artery is used as a mouse model for peripheral artery disease. So looking at that type of hind limb ischemia, a non-ischemic limb versus the ischemic limb, at day 3, which is early in ischemia induction, we actually see significant downregulation of VEGF receptor 2, so 80% decrease in that ischemic limb relative to the non-ischemic limb. And at day 10, a significant upregulation of that anti-angiogenic receptor, receptor 1, so a 40% increase there. And I'll point out that these differences, this decrease in receptor 2, upregulation of receptor 1, were previously hidden when our collaborator looked at Western blot analysis of whole skeletal muscle. So this type of approach can help unlock, again, sensitive changes that occur, which might allow for improved therapeutic development for the treatment of these diseases. Again, this can be used as a biomarker for tumor progression. I've looked at how these receptor levels change in the tumor cells as well as in the tumor endothelial cells, and that's where we're starting to see significant differences at an early proliferative state versus the metastatic state of this tumor. So this type of quantitative approach can again be used to monitor tumor progression. It can also be used to understand the regulation of these receptors. I've looked at how VEGF can regulate these receptors, and receptor 1 is significantly downregulated, receptor 1 is significantly upregulated with increasing VEGF concentration. So here at 1 nanomolar VEGF, on a cell-by-cell level, we see that really corresponds to a shifting of the population, so a more heterogeneous population. Receptor 2, that downregulation that you see here is really due to a more homogeneous population expressing low levels of receptor 2. Receptor 3 doesn't bind VEGF-A, so you don't see a change there. And then neuropilin 1, again, proangiogenic receptor, is downregulated by high levels of VEGF by a shifting of the population to low level of these receptors. And then finally, this type of quantitative approach can be used basically multiplex to better understand these models and to expand our computational models. I speak of VEGF as the primary molecule involved in angiogenesis, but of course there are a number of other molecules involved in this process: PDGFs, angiopoietins, thrombospondin. And understanding many of these other receptors will again allow us to create models that are more physiologically accurate. So this is our previous model, which has only considered VEGF and its receptors. And our goal is now to include PDGF, FGF, angiopoietin, as well as other cells within the tumor microenvironment, as well as in the blood that are critical to these processes. And we're also doing this in collaboration with Arif Massoud in civil engineering, combining his very elegant blood flow models with our molecular models to really understand therapeutic development. But what this would require is being able to multiplex, basically quantify multiple receptors at a time, and as I showed you, multiple cell types at a time. And this is work that Felipe Lee-Montiel, a postdoc in my lab, is now doing, basically creating this type of multiplexing platform to in a high throughput manner, quantify these receptor levels. So by doing all this, combining all these different approaches, we'll be able to design, again, optimized therapeutics that can really look at some of these systemic parameters like blood pressure and dosing, as well as identifying novel targets within these tyrosine kinase receptors, identifying novel combinations of these receptors that should be targeted, as well as identifying novel cellular molecules within the microenvironment that should be targeted. So at this point, I hope I've been able to leave you with the concept that nanotechnology, along with computational modeling, going between that type of iterative approach, can really help us understand what's happening within the vascular system. And by doing this systems biology approach, we have a wonderful platform for testing and advancing therapeutic development. So at this point, I'd like to acknowledge my collaborators at University of Virginia, Brian Annex, who was involved in the first trial of VEGF in the use in therapeutic angiogenesis. So it's been an honor to work with him in some of these hindlimb ischemia studies. Stacy Finley, as well as Alexander Popple at Hopkins, as well as members of my lab, Felipe Lee-Montiel, who, as I mentioned, is doing that multiplexing technology, and a couple undergrads in the lab who are now looking at some of these heterogeneity questions that I mentioned on the cell-by-cell level and adding that to our computational model, and of course, funding sources. And of course, thank you for your attention. Open it up for any questions you might have.
What do we know about the dynamics of these receptors on cell surfaces in terms of how long do they stay up there? Do they get degraded and go back in? And then I assume your numbers are like a sort of an average steady state average over the cell cycle.
Right. So I showed you the ensemble average. I showed you the cell by cell. What I don't what I kind of gloss over is the fact that, yeah, that these are very dynamic receptors, actually. So here I show, actually, over time, between 0 and 30 minutes, the dynamics of these receptors in the presence of VEGF, so 1 nanomolar VEGF. So these receptors are very dynamic in the sense that receptor 1, receptor 2, they're trafficked onto the cell surface. I guess constitutive, well, there's no constitutive recycling for receptor 1. About 50% of the intracellular pool of receptor 2 is recycled back to the cell surface. So yeah, the population analysis is really just a snapshot in time, but I think that should give you an idea of how that's, what the, I guess, the range of receptors that could exist on the cell surface.
I'm also just curious what multiplex particles you're making.
So we're using, well, we're looking at quantum dots, of course, because of the shorter peaks, so, and lower photobleaching compared to something like phycoerythrin, and the fact that we can use multiple quantum dots at a time. I understand that there can be some blinking involved in quantum dots, so that's something I think we'll have to optimize as we're developing that.
All right. If there's no further questions, thank you for a very nice presentation.